We know why gasoline prices are going up. This administration has declared war on the fossil fuel industry. We now know why food is going up, because we have transportation issues, supply chain issues. But what about pharmaceuticals? What about healthcare? Why is that going up? Standing by, hopefully with answers, is the managing partner at PCS Advisors. We've had Paul Seegert on the show many, many times. He has answered many, many questions. And so now, Paul Seegert, welcome to 700 WLW. And how are you on this glorious Saturday?
I'm doing great. How are you?
I'm doing okay. I would be a little ticked off if I was working for somebody and the cost of insuring my family for my health care keeps going up and up and up. 5% a year, you probably don't notice it. 12% year to year, you'll notice it. Why is it going up?
Yeah, and we're coming in from a trend of many years since the Affordable Care Act kicked in. When you look back, employee pay increases have been outpaced consistently by the increase in payroll deductions to pay for health care, which, as you mentioned, has been going up around 6% a year and could go up as much as double that this year, maybe even more. And there's a lot of contributing factors. We drove up the cost of labor during the pandemic. You look at what it costs to get a nurse in a facility today. A traveling nurse made $1,900 a week before the pandemic, and they're up to $3,500 now with big signing bonuses. Burnout, people leaving the field. So labor costs have gone up. All the other effects of inflation that affect every other part of our lives also affect healthcare. And then part of the story that we don't talk much about is the fact that our health system, the way we all pay for healthcare in this country, relies on making the profit margin for the industry at large, for the most part, on employer plans. And in a way, they subsidize the government-provided care. So if you have Medicare and Medicaid, and you show up at a hospital, that hospital very well could be losing money on your transaction. So then they have to turn around and charge these employer plans 3.5, depending on the market where you live, they could be charging your plan 3.5 to 12 times for the same procedure as what they would charge someone that had government-provided care, which also blows a bunch of holes in the argument that people make around we could solve all this with government-provided care. Well, not if government-provided care isn't paying for its own level of service.
Let me just get this before we go on. So if I show up at a hospital and I've got Medicare Part B, and I obviously would have Medicare Part A, whatever I'm treated for, the government would be charged less than if I were 50 years old and I'm showing up to get a procedure done at a hospital and I have an Anthem policy or a Blue Cross Blue Shield or you pick United Healthcare, whatever it may be. So the government caps, the government puts a cap on what a hospital can charge, but if it's some other plan like a United or an Anthem, hey, it's turn them loose, Bruce, whatever it takes. Is that what you're saying?
That's right. Yeah, you basically have three classes of payers in this country. To take a really complex business model and boil it down simply in a short explanation, you've got three classes of payers. If you show up with a government-provided plan, Medicare, Medicaid, they need 120% of what they get from that transaction in some cases, maybe even 140 just to break even. And then if you show up and you have a plan, a jumbo employer plan, then they might make a reasonable amount of profit on that transaction. And then you have everybody else, individual plans, small employer plans, mid-size employer plans, which represent millions and millions and millions of people. They'll charge those plans 3.5 to 12 times what those other categories pay. So they're piling on those employers to prop up the whole system. And that's really never discussed. And when anybody models out how single-payer healthcare would cost less, they don't account for the fact that the quality that we get today is heavily subsidized by employers who overpay while the government underpays.
So this is a scheme that's going on between hospitals and insurance companies. That's what it sounds like. Am I right here?
Yeah, I would say that's an accurate description. I mean, we've changed the way the business works from from a reimbursement standpoint, when we brought in the Affordable Care Act, we told insurance companies so long as they spent 80 cents of every dollar they took in premium on a claim, they could keep 20 cents. So they do better when claims costs go up. And that's true for these employer plans that we're talking about, not for the Medicare, Medicaid. That's a whole different model. They're really doing price control there. Mm-hmm. But in this employer market, they put them in a cost plus model. So you have the insurer who traditionally is supposed to be making sure that the hospital systems, as an example, aren't piling on. Now that we've given them a kind of a misaligned interest, or we've aligned their interest against the success of the system, against the success of these employers and individuals, because they do better when claims costs go up.
So this scheme between hospitals and insurance companies, the people that pay initially are the companies, and then that trickles down to the employee, and therefore that's why in 2023 the premiums are going up 100% more than what they would go up in a normal business deal. So in other words, you know what rolls downhill, and it rolls squarely on the lap of the employee. That's what sounds like what's happening here, right?
Absolutely. And employers they're left with very limited options. They can absorb the increase at the employer level, or frankly, they're faced with having to pass at least some of it along to the employees because of this whole situation I described, where employers are shouldering too much of the load, frankly. And so then you have a situation like we have now, where just on TransUnion, we've got $198 billion in medical debt. 58% of all third-party debt that's in collections that gets purchased by law firms that are, calling people and in collections is medical bills. Mm-hmm. So we've created these plan designs that are really, a lot of people are functionally uninsured. When you look at each year how much bigger that max out-of-pocket gets for an employee, we're up this year at renewal time. Many employees are going to find out their new max out-of-pocket is $9,100 for an individual. That's a lot of money. Yeah. Especially when you can't even fill up your gas tank. You know?
So if indeed this whole problem begins with a scheme between hospitals and insurance companies, why then are we not seeing more action on that particular problem from the people that govern this country, which would be, the men and women we send to Washington, D.C., who seem more concerned with hilarity than things that actually concern you and me? And it doesn't matter whether they're Republicans or Democrats. They're all tied up with whatever nonsense that goes on inside that beltway. I lived there for 5 years. I know what goes on there. I've seen the sausage made. Why is the government not more involved in something that is an actual detriment to the people that send them there and a benefit to insurance companies and hospitals? Have we figured that one out yet?
Oh, absolutely. If I put it in one word, it's called lobbying. And you can just look at the hospital transparency rule as an example of what I mean. It was part of the original Affordable Care Act. Hospitals were supposed to publish their pricing so that at some point we could actually shop as consumers like we do for everything else. And they fought it in the courts for 11 years, finally lost. January 1 of last year, they were supposed to start publishing their pricing, and the fine that was attached for non-compliance was $300 a day. A mid-sized hospital is running billions of dollars. Yeah. So who cares about $300 a day? And then they upped the fine. So naturally, the compliance was, not there. Then they upped the fine to $2 million. $2 million sounds like a lot of money to you and me, but if you're running a $10 billion hospital balance sheet, who cares about $2 million either? So you have 0.5% of hospitals in the three largest chains as of this moment are in full compliance with the transparency rule.
3.
That's where we are.
Just 3.
0.5% of hospitals in the three largest chains. It's like 2 or 3 hospitals, yeah.
Wow. Wow.
I mean, you have small rural hospitals that are in better compliance, but they were never the problem.
So you've got the hospital lobby. Well, by the way, does that have a name, the hospital lobby, or is it just called that, the hospital lobby?
Yeah, well, that's what I call it.
All right, so
the name they prefer, but yeah.
So the hospital lobby is providing money to these people that we elect and send to Washington or want to run for office in Washington, and therein lies the root of the problem, is what you're suggesting.
Yeah.
Okay, so
and
it's not hard to...
pharmaceuticals and everything else.
Yeah, so pharmaceuticals, drug manufacturers, hospitals, insurance companies. So it's not real difficult to find out who is getting this money that's been elected to public office in Washington, D.C. My guess is it's a matter of public record, and it wouldn't take much for a constituent like me, you, or anybody else to do a little deep dive on the internet and find out who's getting what. That'll lead you to believe to where the problem is, right?
It will, yep. And some of it is easy to find. Some of it's a little more difficult, but you can certainly get an idea. And I've called it for a long time precision giving. Right? They give with such precision to both sides of the aisle. This is true for Big Pharma. This is true for the insurance industry as a whole, really. Our payment model, this medical industrial complex, precision.
I think we lost Paul. Did we lose Paul? Matt, did we lose Paul Seegert? His line went dead. All right, get him back and tell him thank you, and we'll just pick up his final thought, which was my final thought. It may take a little effort on your part, but when you see this going up 10 to 12%, much as 12% next year, one would be led to believe that if we continue to be in this economic crisis that we're in, and from all indications, it's not going to be resolved at least for another year, maybe a little bit longer, one would think in 2024, it would go up as exponentially as it's going up this year. So at the end of 2024, if we're sitting here with our premiums up 24% over a 2-year period, and we know the scheme between hospitals and insurance companies is what's causing it, and we know that Congress doesn't really want to get involved all that much in this for whatever reason. I don't know. Maybe they're tied up with the nonsense we see from the January 6th Commission or anything else that has absolutely nothing to do with you and me and living a better life. Follow the money. Find out who's getting this money and hold their feet to the fire. Hey, Mr. Congressman in my area, or Ms. Congressman, or whoever it may be, what are you doing about this? Why are you getting all this money from this lobby group and we're not making any headway here? And the beautiful thing about people that are in the House, they're up every 2 years. So you can deal with it almost directly and promptly. But it's absolutely outrageous. Yes, if your premium this year was $300, in 2023, you could see as much as $36 more out of your hide. Compound that with the price of gas, what eggs cost, what bread costs, what clothes cost. And it's not hard to figure out why we're in the economic mess we're in. Thanks again to Paul Seegert, Managing Partner, PCS Advisors. You can find him at pcsadvisors.com.